Chlamydia can be considered as an interface between bacteria and viruses. So there are a lot of characteristics that are quite intermingled between the bacteria and viruses when we are talking about the chlamydial infections. It can be the characteristics at the biochemical level, or it can be the messenger RNA or the DNAs that are present, or the presence of the inclusive bodies that is a distinguishing characteristic of the viruses that is present among the chlamydial infections. So there is a list of chlamydial infections that we're going to discuss in our lecture today. The most importantly, we have trachomatis infections, we have psittacosis, which is also known as the parrot's fever or the bird's fever. Psittacosis is basically related to the infections that are related to the pet birds that are kept at home, and these environmental infections are quite commonly affecting the eyes, or even it can affect the skin of the patients. Then we have lymphogranulomatous infections that is basically affecting the lymphatic system of the person. Again, the causative organism would be a chlamydial infection. Most notoriously, we have trachomatis infections, and the complications that are related to the trachomatis infections are the trichiasis that are the presenting complaints in the outpatient departments that we are mostly dealing with in our outpatient departments, or even in the emergency departments when we're working out there. So over here, talking about the genesis of the chlamydial infections, one should know that we have the chlamydial infections. On the other hand, we have the species that are related to the chlamydial infections are primarily the Chlamydia trachomatis, that is the TRIC agent that is quite common in the humans. The serotypes that are involving the Chlamydia trachomatis infections, they range from A, B, B with a small a, and then we have C. So these are the genotypes or the serotypes that are commonly used when we are naming them or when we are documenting these chlamydial conjunctivitis infections. Moreover, we have the ocular diseases, that is the hyperendemic trachoma that is present. And the transmission that is related to this Chlamydia trachomatis is usually the eye-to-eye, or which is also known as a direct transmission cases. When we say eye-to-eye, it can be an airborne infection, or even it can be a vector-related carrier that is involved over here. The vector-related carriers would be including the flies, or even it can be the other insects. So directly the discharges or the infectious material can be transferred from the infected eye to the other eye, which is normal, or it can be contaminating the eye of another person who's using the same materials. It can be the towels, it can be the use of the handkerchiefs. All of these are basically the sources of the transmission of infection from the infected eye to the normal eyes. So over here we have another strains that is ranging from D to K. Paratrachoma is the name of the ocular disease that these strains are causing. We have the neonatal and the adult inclusive conjunctions over here. Then we have the transmission is basically not related from the infected eye to the normal eye. It is from the genitals that are affected. It can be the urethritis in the males, and it can be the cervicitis in the females that is affecting the normal eyes of the individuals. So the infectious material is basically traveling from the genitals to the normal eyes. Then we have the lymphogranulomatosis. It is in humans, it is basically the genes or the strains that are present in the humans are the L1, L2, and the L3 strains that are quite notorious. We have lymphogranulum venereum conjunctivitis, that is the name of the disease that these strains are causing. The transmission again is from the genitals to the eye. So again, one have to focus on these factors, that sometimes it is the infectious material of the eye itself that can cause the infection, and sometimes in some of the strains it is from the genitals to the eye. So the sexually transmitted diseases are quite notorious to finally develop into these chlamydial kind of conjunctivitis cases. So once you have a patient, or you are treating a patient, or you are basically investigating a case of chlamydial conjunctivitis, the labs would include to screen the patient of any sexually transmitted diseases as well. Finally, we have the chlamydial psittacosis, which is animals related. It's also known as the pet fever, or in other words, it's usually quite notorious that the parrots or the birds are responsible for spreading this kind of chlamydial psittacosis. So the animals are sometimes responsible for spreading this kind of a disease. The etiology in trachoma is the chlamydia trachomatis. So the causative organism is chlamydia trachomatis in such cases. What are the primary characteristics of this chlamydia trachomatis? As we were already dealing with this, these chlamydial infections have the properties that is basically an interface between the bacteria and the viruses. So even the replication would include the steps that are quite similar to the bacterial infections or even the viral infections in a lot of cases. The predisposing factors can range from the environmental factors, and then we can have age, that is one of the predisposing factors. So they are quite common towards the extremes of the age group. Either it can be the neonates that are mostly affected in these cases, and on the other hand, we have the older age groups that are mostly affected by such kind of infections. So these are the age groups that are mostly affected, the adult age group, and then we have the neonatal age group. The modes of transmissions would remain the same in both of the cases. Then we have a female predisposition. Whenever we are comparing the gender as the predisposing factor, we say that the females are more predisposed to the development of such chlamydial infections, and that may be one of the reasons behind this predisposition can be the immunity that is quite lowered in the females as compared to the males. Then these trachomatis infections are more common towards the Negroes, and that is one of the racial predisposition that is noted down in the pattern of the chlamydia trachomatis infections. Climate, a hot and the humid climate is more prevalent to the development of such infections. And then a lower socioeconomic group, belonging to a low socioeconomic group, is another risk factor to the development of such conditions. One of the factors, or one of the playing factors over here, can be the poor hygiene that is followed in such closely packed areas or in areas where there is less ventilation provided at the home. So again, the environment and the socioeconomic status of the patient is very important. All of these predisposing factors play a very pivotal role. So whenever you have a patient of any kind of a conjunctivitis, and obviously the pictures would be quite confusing when you're looking at the patient clinically, because the features would again be of the pain, the redness, photophobia, and that would be quite similar to a chronic kind or a venereal kind of a conjunctivitis. So you'd be basically focusing, whenever you're writing down the history from such a patient, you'd be focusing on all of these predisposing factors that can make the person more prone to the development of chlamydial infections, and you can suspect trachoma in these patients. The sources and the modes of transfer, we have conjunctival discharge, which is the basic source of infection in these patients. The airborne or the waterborne modes are very important over here. So it can be the airborne droplets that can cause the infection, and it can even be the waterborne diseases in such patients. For example, swimming pools are a very notorious source for the carriage of such transmissions of infections, because that is basically one of the sources in which the water can be contaminated, and if it is not properly chlorinated, it can result in such trachomatis infections in the individuals. The vector transmission through the flies is again very important over here. Flies play a very important Victorian role over here to carry the discharge material from the infected eye towards the normal eye. Then it can be a direct material transfer. It can be when you're commonly using the personal products. For example, it can be the towels, it can be the handkerchiefs, the bedding. All of these are the things for the personal usages. And if there is no personal hygiene maintained at the level of the home of the patient, then it can be quite evident that such materials can be transferred from the infected eye of the patient towards the normal individuals who are surrounding the patient. Then we have the clinical features. So the phase of the active trachoma is very important over here. Whenever we are looking at the patient, you have this patient at your hand and you're looking at him or her, and you're just seeing that the patient is having a lot of discharge. It's basically a mucopurulent discharge that is present at the canthi, at the medial or the lateral canthus, and at the lower border of the eye. And it can be even resembling a blepharitis or the lid infection as well. So we have a phase of active trachoma in which we have to look for the signs in the conjunctiva of the individual, and even we have to look at the signs of the cornea. So the signs at the conjunctiva would include the conjunctival irritation and the conjunctival inflammation, of course. It would include the fornices, and there would be this typical picture of active trachoma over here. Now, this would consist of as you all know, basically, the conjunctiva has two parts. It has the bulbar part of the conjunctiva, which is covering the eyeball, and then we have the palpebral part of the conjunctiva, which is covering or which is forming the innermost layer to the eyelids. So if we retract the eyelids, these papillas or this inflammation of the papilla is very commonly seen in such trachomatis infections over here. And then there would be the follicle presentation. So just by looking at these features, you have the papillas, you have the follicles. It can be confused with the papillary conjunctivitis, or it can be the venereal conjunctivitis. Even it can be confused with the follicular conjunctivitis. It can be a bacterial follicular conjunctivitis. So these are the typical features, and these are the most common features towards these trachomatis infection. And obviously, there would be the signs of redness and swelling that are also observed in these trachomatis infection. Then there is this neovascularization. This neovascularization is basically known as the pannus formation. Pannus, as you can see over here and you can appreciate over here, this is basically the development of the new vessels at the bulbar conjunctiva, just in proximal relation to the limbus. So there would be this neovascularization that is noted down over here, and these are known as the pannus formation over here. It can be of a regressive type and it can be of an aggressive type. So it depends upon whether there is any constricture of the vessels that is noted down over here or not, but still this pannus formation is quite similar, or it's quite a distinguishing feature for the trachomatis infections over here. Then we have the Herbert's follicles. Herbert's follicles are basically present on the corneal epithelium, and they are basically due to the result of the damage that is caused to the corneal epithelium, that these Herbert's follicles, they come and they are clinically present when you look at the eye of the individual. All of these features can be present on the normal eye inspection. And even it can be more distinguishable when you basically ask the patient to sit on the slit lamp and you clearly or keenly observe the eye of the individual. We can appreciate the papillas, the follicles, And the distinguishing features would be, on the other hand, the Herbert's follicles and the Pannus formation, which is the neovascularization that is present on the bulbar conjunctiva, and that is quite a distinguishing feature for the trachomatis infections over here. So the clinical features, as you may relate to, the face of the active trachoma is characterized by this Pannus formation. And as you can see, this is the clinical picture for the Pannus formation. It's quite visible over here that you can see that there is a whole range of neovascularization that is present at the limbus. It's divided into the regressive type, and then we have an aggressive type of the Pannus formation over here when we say it's the phase of the active trachoma over here. Now, once this phase of the active trachomatis or the active inflammation, it ends, then it moves on to the phase of the cicatricial trachoma. Trachoma, as you all know, is one of the leading causes of the blindness. Almost 15 to 20% of the preventable diseases which lead to blindness is the trachomatis infections that are leading to, or that is the basic cause to the development of the blindness in these individuals. Now, what are the complications that are foreseen when the trachomatis infections are left untreated? It can be the development of the scars or the development of the cicatricial tissue. That is very important. So once you have a look at this conjunctival scarring, you can appreciate that there are these star-shaped scars that are present over here and that are quite ambiguous. The chlamydial infections, or the bacteria or the chlamydia that is responsible for such infections or for such conjunctivitis, are epitheliotropic. Now, what does this word actually means? It means that the chlamydia viruses, or the organisms that is basically the etiological organisms for the development of these trachomatis infections, they enter the epithelial cells, and then there is a formation of the initial bodies that are present out there. Then after that, these initial bodies are transferred towards the development of the elementary bodies. This is the second step towards after the infectious state has occurred, after the active phase of the inflammation has passed on. And once there is the development of these elementary bodies, there is an outburst of these cells, of these epithelial cells. And once these epithelial cells are outburst, and they are scarred, there is the development of the concretions that can be even seen due to these mass diffusal of the epithelial cells. So the chlamydial infections, they are targeting the epithelium of the conjunctiva. They are epitheliotropic. This is the mode of infection, or this is the underlying mechanism that is happening out there. So once the phase of the active inflammation has passed on, there is a phase of scarring due to the damage that has occurred to the epithelium of the conjunctiva. And this is how it looks like clinically. It's basically this star-shaped development of the epithelial scars that are quietly present over there. And that is the main phase of the cicatricial trachoma that is seen over here. Then we have the concretions. Even these concretions can be confused towards the deposits, towards the fatty deposits, or it can be even confused with the calcium deposits over here. But they're not actually so. It's the damage of the epithelium that has occurred that gives rise to this kind of a visual appearance, which can be confused with the concretions, or these yellowish fatty deposits that are present out there on the bulbar conjunctiva, or even they are present on the palpebral conjunctiva over here. The other complications can be the development of the pseudocyst in the conjunctiva. It can be xerosis. Xerosis is basically a term that is used for a dry eye syndrome. Basically, the lacrimal system, the lacrimal glands are affected in such cases, and that basically gives rise to the development of this condition, which is known as xerosis. On the other hand, we have symblepharon. Now, how do we define this condition, which is known as symblepharon? It's basically when the bulbar conjunctiva and the palpebral conjunctiva, they stick together. This condition is known as symblepharon. Now, why does this happen? It's basically the scarring or the cicatricial tissue that is developing on the conjunctiva that gives rise to this stickiness of the palpebral conjunctiva and the bulbar conjunctiva. The treatments would be, obviously, there are no medical treatments that are available out there to treat these symblepharon conditions. Even these symblepharon conditions can occur in a lot of other infectious states as well. So it's not only the trachomatis conditions, but the treatment would be just surgical in these cases if these symblepharons develop in the patient. Then we have the clinical features relating to it, the phase of the cicatricial trachoma. We have the trachomatis corneal opacities that are quite evident over here. We have the HB bodies over here, and these HB bodies are quite evidently seen over here. Now, it is basically the Holter, Stedler, Pausat's bodies. They are known as the HB bodies, and that is basically giving way to these corneal opacities that are quite evidently seen in the trachomatis infections. Then we have the trachomatis Herbert Spitz. It's again the damage to the epithelium that is occurring in the conjunctiva. It is the bulbar conjunctiva that we're talking about over here. And then we have the regressive pannus. So it's basically the phase of the cicatricial trachoma that you can see over here. It's giving rise to the opacities, that is the HB bodies. That can be even seen on microscopic findings or even under the microscope or even under the histological findings. You can observe all of these HB bodies. Then there can be these Herbert Spitz and the regressive pannus, and pannus is basically relating to neovascularization. Neovascularization, again, I would like to emphasize, it's the development of the new blood vessels at the site of damage that is occurring over here. So finally, we have the grading of trachoma. We can grade trachoma clinically. As we have already discussed, we have an active phase of trachomatis infection, we have a cicatricial phase, and then we have a chronic trachomatis conditions that can develop in a patient. So one should know how to grade these trachomatis infections, whether it is a mild, moderate, or a severe case of clinically identified trachoma in the individual. We have McCallan's classification. That is one way of clinically grade trachoma just upon the features that are developing in the eyes of the individual. Obviously, the sign and symptoms would remain the same. We'd be looking at the conjunctiva, and we'd be looking at the corneal features. Either it is the HB bodies, or either it is the Herbert spots or the pannus formation. All of these can be one way to grade trachoma in these individuals. First of all, we have the stage 1. That is the incipient trachoma, or the stage of infiltration in which the chlamydia trachomatis has just entered the orbital conjunctiva or the bulbar conjunctiva and basically infiltrating over there. Then we have the established trachoma, or the stage of the florid infiltration. Now, whenever we say the stage of florid infiltration, it's the development of the follicles, it's the development of the papilla over there that is basically marking this stage of florid infiltration over here. Then finally, we have the cicatrizing trachoma, or the stage of scarring. So once the active inflammation has faded down and the epithelium of the bulbar conjunctiva or the epithelium of the palpebral conjunctiva has been damaged, we can just clinically identify whether there is this patchiness of the scarring that is present on the whenever the eyelids are reverted or not. So it's quite evident not on the bulbar conjunctiva, but it's more evident on the palpebral part of the conjunctiva that we can observe this kind of cicatricial tissue over there. So this is basically the stage 3 over here. After this phase of cicatrization or after this phase of scarring that has developed onto the bulbar conjunctiva or that has developed onto the palpebral conjunctiva, we can we can look for the other signs of the healing that is occurring at the conjunctival margins. We can have the healed trachomas, or sometimes we can see the complications that are seen over here that are also known as the sequelae of the chlamydia trachomatis conditions. These sequelae can be the symblepharon, it can be the xerosis, that is the dryness of the eyes that is observed sometimes. And sometimes it can be the trichiasis that is the most common complication that is related to the chlamydia trachomatis infections over here. So then we have the another kind of a grading that is devised by the WHO. Now this is a more a practical kind of a grading that is devised and that is used for documentation more commonly. We have a TF stage. First of all, that is basically the trachomatis inflammation follicular stage over here. And that is followed on by the T1 stage, that is basically the trachomatis inflammation intense. So basically we start off with a much milder form of inflammation and then we move on to the most intense inflammation in the T1 stage. Then we have the TS stage, that is basically the stage of scarring. So once the infiltration has occurred, the cellular infiltrates have invaded the epithelium and we have passed on with the initial bodies and the development of the elementary bodies, and then there is basically the outburst of these elementary bodies and the epithelial cell damage that is followed on by the scarring of the epithelium of the palpebral conjunctiva. The TT phase is basically the trachomatis trichiasis. Trichiasis, as we all know, it's basically the eyelashes when they are inverted and they act as a foreign body. They come in close contact with the conjunctiva, they act as an irritant, they act as a foreign body, and they damage the conjunctiva and they cause a lot of irritation to the conjunctiva. That is known as a condition of trichiasis. So sometimes this trichiasis is the result of a complication of the trachomatis infections, and this occurs due to the inversion of the eyelids that occurs, and that results in the trichiasis phenomena. So this is known as the trachomatis trichiasis phase or the TT phase. It is abbreviated like that. Then we have the corneal opacities, and then we have the Herbert's bodies, we have the Panis formations. These phases, as we can already summarize, it's basically the TF, T1, TS, TT, and then we have the corneal opacity phase. All of these phases are basically depending upon the clinical presentation of the individual. It's basically obviously relating to the severity of the disease. It's obviously relating to the stage of the disease. As we know the whole process of the trachomatis infections, now we can easily grade the patients when we have them, and the patients can present in any stage. They can present in any grade, and one should know how to basically diagnose these patients. So the diagnosis is again very important, and that is obviously based upon the inspection of the individual. Obviously, you'd be noting down the complete clinical picture and remembering this complete clinical picture. And obviously, you'd be carrying out the lab investigations to isolate the chlamydia trachomatis in the individuals. Then, if these cases are left untreated, there are a lot of complications that we can see in these individuals. Ranging from, we can have the corneal ulcers that can occur in these patients, and this is basically an immunofluorescence technique by which the corneal ulcers are elaborated in a patient in whom we are suspecting such complications after the trachomatis infections. So the diagnosis would be obviously to isolate the organism upon the different cultures. Now, there are a range of cultures that are being used, range from the immunocytology that is done, then we have the McCoy cultures, then we have the yolk sac cultures that are carried out for such diagnosis of the cases. The conjunctival cytology is very important over here because the isolation of the organism in such cases is the mainstay for the definitive diagnosis. We have a range of differential diagnosis. Whenever we have these patients, we can confuse them with the venereal conjunctivitis, with the bacterial conjunctivitis, with the catarrhal conjunctivitis. Whatever the case may be, we have to isolate the organism to get to the definitive diagnosis in these patients. Then we have the detection of the inclusion bodies that can be carried out as well in these patients. ELISAs can be performed for these patients, and this is one of the way in which basically you have the optoacoustic response that is correlated with the concentration of the organism. So if there is a linear regression that is noted down, it is going to point out towards the infectious states with the chlamydia, trachomatis in these patients. Then we have the isolation of the chlamydia. So upon histology, once you send the samples of the discharge even to the microbiologist or to the histopathologist, he must isolate these patients of these creatures or these organisms of chlamydia upon looking at the slide under a microscope. This is one of the mainstay for the definitive diagnosis in these patients of chlamydia trachomatis infections. The polymerase chain reactions, PCRs are done, and then we have the serotyping of the TRIC agents that is sometimes done in the patient. The differential diagnosis can be the trachoma with follicular hypertrophy. So if we have a look at this trachoma with the follicular hypertrophy, the distribution of the follicles is very important. It has to be an angular distribution. If we want to say it's a trachomatis infection, then there can be the associated signs that we are looking for. We already said there has to be the HP bodies, there has to be the pannus formation. We have to look for these associated signs if they are present or not. And then finally, we have the lab investigations that we have to carry out for such patients whenever we are confusing the trachoma with follicular hypertrophy, and on the other hand, it can be a bacterial follicular conjunctivitis. So these are some of the features that we have to look for whenever we are distinguishing these two patterns of the diseases. Then we have trachoma with predominant papillary hypertrophy. Again, cytology is very important, microscopy, isolation of the organism, or it can be the catarrhal discharge that is present in the papillary hypertrophy. That is the mainstay for, or the main diagnostic feature over here. Again, the pH of the tears is very important. In trachomatis infections, the pH of the tears is usually alkaline in nature, so we have to remember this even. And the papilla are quite large in the trachomatis infections as compared to the papillary hypertrophy that is caused by the other causes, for example, bacterial, viral, or it can be the other catarrhal causes over here. So these are the features that we have to look for. It is the cytology coupled up with the labs, then coupled up with the associated features. So when we have a confusing picture and we want to distinguish whether it is a bacterial infection or either it is a viral infection or either it is a chlamydial infection, we'd be looking for all of the associated symptoms, and we'd be coupling these associated symptoms along with the lab investigations that we have at our hand. And then finally, we'd be making a conclusion towards the chlamydia trachomatis infection in the patient. The management of such cases of the active trachoma, it basically ranges, first of all, we have the topical therapy, and that is the most blendable therapy and it is the mostly available. It is much cheaper than the systemic therapy, and so we usually apply this topical therapy for the chlamydial infections. The other benefits for the topical therapy are that the systemic therapy is having the side effects to it, and the topical therapy has least side effects and it is more efficient than the systemic therapy. We can use tetracycline, that is 1%, or erythromycin, that is 1%, and eye ointment is usually advised 4 times a day for 6 weeks. So this is the regimen that is usually followed for the topical therapy in these patients. If the patients do not respond to such kind of a therapy, we can also alternate this topical therapy with sulfacetamide. That is 20% eye drops are usually prescribed to the patient 3 times a day with 1% tetracycline ointment at bedtime for 6 weeks. We usually couple up the topical therapy with the eye drops along with the ointment therapy so that the healing can go on at night as well. Then we can couple up this topical therapy with the systemic therapy in the patients who are unresponsive towards the topical therapy. We can use azithromycin, that is 20 milligrams per kilogram body weight up to maximum 1 gram stat, or 250 milligrams OD for 4 days. Then we can also use tetracycline or erythromycin if the patient cannot tolerate the doses of azithromycin or Azomax. We can prescribe the patient with 250 milligrams tetracycline or erythromycin QID, that is 4 times a day, for 3 to 4 weeks in these patients. Even if the patient is not tolerant, or sometimes the patient is allergic to these drugs, so we can try on with doxycycline in these patients as an alternative, 100 milligrams orally twice daily for 3 to 4 weeks. So these are the typical regimens that are prescribed for the trachomatis chlamydial infection in the patients. Then there is another therapy which is basically a combination of the topical therapy with the systemic therapy, in which we have the tetracyclines or erythromycin eye ointment 4 times a day for 6 weeks. And sometimes we also combine it with the oral Azomax, that is azithromycin, first choice of drug. It is the primary choice of drug, that is the azithromycin. And if it is not tolerated in the patient, we can use tetracyclines or erythromycins, that is 250 milligrams orally 4 times a day for 2 weeks. The treatment of the trachoma sequelae, that is the complications of the chlamydia trachomatis infections, are the concretions are sometimes removed with hypodermic needles, and that is basically a small surgical procedure that is performed for the removal of infections or the concretions in the patient. Then finally, we have trichiasis, that is treated by appellation, electrolysis, or cryolysis. But obviously, there has to be a surgical treatment for the inversion of the lid, first of all. And then we can have the cicatricial entropion, that is corrected surgically. And finally, we have the conjunctival xerosis, that is treated by the artificial tears. It is a dry eye syndrome, so it has to be treated with the artificial tears, and it has to be dealt in this particular similar way over here. There is a safe strategy that has to be followed. It's obviously not the part of the management, but it is the part of the prophylaxis, that is the prevention of the trachomatis infections in the patients. The S stands for surgery. It's the tertiary prevention that is carried out in these patients. We have the antibiotic use, that is the secondary prevention. As we say tertiary prevention, it means that it is the prevention of the complications in the patient. We have A, that is the antibiotic use, and is a secondary prevention, that is towards the development when the patient is going towards the sequelae of the condition. We can prevent such sequelae by the use of the antibiotics. The F stands for facial hygiene, and this is the primary prevention in the patient. How does this facial hygiene comes into play? Basically, after you educate the patient properly, you personally educate the patient about the spread of the infection. It can be the complete prophylaxis of the sexually transmitted diseases, and you have to educate the patient that this kind of an infection is basically transferred either from the genitals to the eyes, or even it can be a direct vector transmission or direct discharge transmission from the infected eye towards the normal eye. Now, this can happen by the sharing of the personal items. For example, it can be the use of the sharing of the towels, the handkerchiefs, the bedding, etc. It can be one of the causes towards the spread of such disease. Then we have the environmental changes, that is the primordial prevention. As we say, there has to be a lot of ventilation. There has to be a less hot and a less humid environment if we want to prevent this kind of trachomatis infections in the patients. Finally, we have the adult inclusive conjunctivitis. So it's basically the urethritis or the cervicitis that is the basic causative factor behind the development of inclusive conjunctivitis. Serotypes D to K of chlamydia trachomatis are responsible over here. The transmission is either through the contaminated fingers, the contaminated water of swimming pools. These can be the modes of transmissions in such cases of inclusive conjunctivitis. The clinical course of the adult inclusive conjunctivitis, it is the ocular discomfort or the foreign body sensation. Then the patient would complain of discomfort in the sunlight or exposure towards the light. That is, a mild photophobia is also experienced by the patients. There would be a mucopurulent discharge in these patients. The superficial keratitis or preauricular lymphadenopathy, submental, submandibular lymphadenopathy has to be observed as well. Then there are the conjunctival hyperemia cases and acute follicular hypertrophy that is noted down in these patients. The differentials would include the acute follicular conjunctivitis can sometimes be confused with such inclusive conjunctivitis cases. And the treatments would obviously include a topical therapy, that is the tetracyclines, eye ointments 4 times a day for 6 weeks. And then we have the systemic therapy, that is azithromycin 1 gram, tetracycline 250 milligrams, or alternatively, we can use erythromycin, that is almost 250 milligrams. Doxycycline 100 milligrams is sometimes systemically prescribed to these patients as well. Prophylaxis include the improvement in the personal hygiene. Of course, you have to educate the patients towards the regular chlorination of the swimming pools. And then the patient's sexual partner has to be examined and has to be treated as well, because he is at risk to the development of this inclusive conjunctivitis as well. So in this lecture, basically, we summarized the basic chlamydial infection, chlamydia being an interface between the bacteria and the viruses, and what are the range of infections that can occur due to these chlamydial infections. So that is the end of this lecture. Thank you for watching sqadia.com.